Again, thanks for having us here, and I've very much enjoyed my time in Saudi Arabia, including outstanding dinner last night. I'm still full from that. My topic today is cervical spine deformity, and it's obviously a very widespread kind of problem, and your incidence could go up to 100% if you consider any kind of positive sagittal imbalance in older patients a true disease state. But the reality is the natural history and the incidence vary based on what you're talking about, and I'm not going to emphasize that today. I did spend some time changing my slides based on some overlap in my talk with Dr. Wang's talk from yesterday, and so I'm not going to spend as much time on clinical assessment. I'm going to spend more time looking at decision-making and techniques for intervention, and then where we have it, some discussion of outcomes and complications. I'd like to start with this case, though. This is a patient that was referred to me about a year ago from an outside institution. He had had myeloradicular problems with weakness, balance dysfunction, and arm pain. He underwent this 2-level corpectomy with an expandable cage, but post-operatively, while his radicular problems improved and his myelopathy seemed to be getting better, he reported increasing neck pain and positive sagittal imbalance, difficulty holding his head up. The surgeon then took him back to the operating room for a posterior stabilization, which you can see on the right here, which unfortunately only made the problem worse. And the question becomes, now that this patient's in your office, what do you do with this problem? But really a good first question would be, why did this happen in this particular patient? Because understanding that will have a much better, will give you a much heads up in terms of what ways you can address the problem. And one issue in this particular patient is their bone quality. The patient's not severely osteoporotic with a T-score of -2.2, but a 2-level corpectomy and soft anterior column bone is challenging in any case, and certainly in this particular patient. And we see changes consistent with that. As we look at the CAT scan myelogram, you can see that this very powerful expandable cage was placed, which has the advantage of a wide footprint and therefore is generally considered a good device for corpectomies, but the expandability is a very powerful option, and often we see these cages overexpanded. In the cervical spine, in that about 1/3 of the load is carried through the vertebral body anteriorly and 2/3 through the articular pillars posteriorly. If you overexpand the cage, all the load goes through the anterior column, and you see what you see here, which is pistoning of the cage through the end plates with collapse. So in this particular patient, you could say that he had the wrong index surgery. A 2-level corpectomy in a patient with poor quality bone could have been stabilized posteriorly immediately. The wrong levels were done with the posterior approach. There was a failure to address the key problem at the time of revision and relatively poor execution throughout. So it's sort of a reach and a fail. I think from a mechanical perspective, the surgeon that performed the surgery simply didn't understand the relevant mechanics, just as the person locking up his bike here didn't really understand how locks work. So what do we do with this problem? In my practice, the first thing I want to think about is, does the patient have cord compression or progressive myelopathy? In this particular case, the good news is the patient is neurologically stable and there's no significant cord compression. The next step for me is to make a list of the patient's problems and then try to devise a treatment strategy that offers the smallest possible surgery while also addressing all these problems. And you can see we have issues of bone quality, fixation point loss, anterior column support, and then deformity in both the coronal and sagittal planes. So my plan was to realign the patient and then perform posterior fixation, selecting strong anchors posteriorly. Once that's done, try to achieve anterior column support by removing that cage and then replacing it with a longer strut. And you can see that transpedicular instrumentation was placed at C2, 7, and T1. Bicortical lateral mass screws were used to revise the failed lateral mass screws based on the bone quality and the revision status. Here you can see the postoperative CT with a long mesh cage. The x-rays at 2 weeks still show significant sagittal imbalance. A reasonable correction of the cervical alignment was achieved, but there's obviously marked weakness in the extensor musculature, and for me, a patient like this will be braced until such time as their extensors start coming back online. You can see by 6 months, they're holding their head up much better, and at this point, I would start weaning the brace. So here again is the patient's pre- and post-operative studies. The patient actually did very well from a clinical standpoint. Still has some neck pain, felt mainly at the occiput, but is doing well from a neurologic perspective, and bone healing has been excellent. So as we work through these patients, what are our options? The reality is non-operative management is typically not a great selection in severe or progressive deformities in patients with cord compression. We know that Dr. Wang talked about osteotomies, but the truth is the vast majority of these patients are either going to be treated with an anterior approach, a posterior approach, or the workhorse, an anterior-posterior approach. So these are obviously very different sizes of surgery with very large differences in morbidity. We're not going to talk about the osteotomies in that they were covered yesterday. Our goals at the time of surgery are to correct and fuse the deformity, ideally with a normalized sagittal vertical axis, but typically that's not possible, especially in patients with poor bone quality, and straight may be an acceptable compromise position. We certainly need to decompress any compressed neurologic elements, and we want to, as best we can, relieve the patient's pain. In terms of decision making, it's important to understand spinal anatomy and spinal mechanics, but in particular, this patient's pathoanatomy and pathomechanics. The flexibility of the deformity is very important in decision making, but so too are a clear discussion with the patient and their family about goals and expectations of the procedure and the associated complications that can be attendant with these sorts of large operations. In assessing their neurologic compression, it's important to understand if there is any, if it's anterior, if it's posterior, whether it's disc level only, whether it's retrovertebral. The deformity itself can cause problems with the cord with a stretch myelopathy, which we'll discuss in a second. There are often very severe looking deformities that are quite flexible, like dropped head syndrome, and these typically can be treated with a simple posterior approach. There's also the very rigid deformities associated with ankylosing spondylitis that require osteotomies, but in the majority of degenerative indications and the majority of iatrogenic postoperative indications, it tends to be a fairly in-between situation in terms of stiffness. So we're not really talking about the chin-on-chest patients here. Those are better candidates for osteotomies. Dr. Wang talked a lot about alignment issues and the C2 plumb line or sagittal vertical axis versus C7. I think this is important for us both in terms of workup, but also in terms of how we select our surgical solution to the problem, because as the head moves forward, that vector of loading force increases, sort of like the Leaning Tower of Pisa wants to lean more and faster the farther over it goes. And so recognizing your final and initial alignments will have a lot of impact in terms of how many anchor points you need posteriorly. This is an example of the stretch myelopathy we see in some of these patients as their cord drapes over the kyphus despite a wide posterior decompression, and how restoration of alignment can be very helpful to the cord in that setting. Dr. Wang talked about the sagittal vertical axis and the T1 slope. I'm not going to belabor that now, but it is important to look at that and try to get a sense of what would be normal for the patient. In terms of flexibility, there are a number of ways of looking at this. I think one critical issue is to get a fine cut CT and look at the status of the facets. It's important to get x-rays over a bolster, get x-rays in traction if necessary. Comparing the upright alignment with the patient's supine studies, such as their CT and MRI, are important here. In these larger revision cases, it's important to understand any potential complicating factors, such as aberrant vertebral artery anatomy, and an MRA can be helpful. Understanding the patient's bone quality, both on CT and DEXA, is helpful. Occasionally, 3D modeling can be helpful in these patients. So which way do we go at the time of surgery? The anterior approach has a number of advantages. After a 3-column osteotomy, it's certainly the most able to recreate lordosis in these patients. You're able to restore the anterior height with structural grafts, which also helps you with your anterior load bearing. It offers the ability for direct decompression of anterior neurocompressive pathologies and may avoid a difficult posterior revision. The disadvantages are, of course, that the fixation in the cancellous vertebral body is less secure than posterior fixation, especially in osteopenic patients. And there's the mechanical disadvantage of all your fixation being anterior to the instant axis of rotation of the spine. It does not restore the posterior tension band that's often missing, especially in previous laminectomy patients. So typically an all anterior approach is indicated in patients that have a fixed deformity that's not particularly severe and not ankylosed with good bone quality. Typically, patients that have major anterior compression will require an anterior approach, either alone or with a posterior approach. So too will patients with significant structural insufficiencies in the anterior column. The contraindications to an all-anterior approach include fused facets. And sometimes a previous ACDF, the facets will have gone on to fuse, and sometimes they won't, but it's important to understand that. In patients that have fused facets, you want to start with a posterior approach to osteotomize those facets before attempting an anterior reconstruction. But here you can see a patient that had a previous laminectomy and a multi-level anterior fusion successfully treated with an anterior-only approach at the Cleveland Clinic, doing anterior column osteotomies and then multi-level fixation based on the fact that their facets were not fused. An all-posterior approach is typically indicated in patients with flexible and passively correctable kyphosis. It requires that you get sufficient cord decompression through realignment alone. You need sufficient anterior column load-bearing ability and a reasonable disc space. The advantages here are obviously superior fixation versus anterior plates. This fixation does act posterior to the axis of rotation and helps restore a tension band. And particularly if you use 3-column fixation, such as pedicle screws, you're going to have much more sound stability. And for any significant deformity, typically my end levels will be the occiput, C2 most commonly, and then inferiorly C7, T1, T2, somewhere in that region. And here you can see an example from Dan Rue looking at that. The disadvantages in terms of the posterior approach are often soft tissue issues, especially if the patient's had a previous laminectomy. Often the extensor muscles are atrophied. This will lead to significant issues with wound healing problems, implant prominence, wound complications such as infections, and there's less surface area available for bone grafting. Certainly, while the fixation is stronger posteriorly, if you don't have anterior column support, you risk pullout, especially of your proximal screws. So for a lot of these patients, the workhorse approach tends to be an anterior-posterior approach, which has the advantages of both of the other approaches, but also combines the disadvantages of all those other approaches in terms of significantly longer operative times, blood loss, and the possibility of airway edema, peg and trach placement in some cases, and so on. Typically, this is done in patients that need additional posterior fixation after an anterior reconstruction, so a 3-level corpectomy or a 2-level corpectomy in soft bone. Patients that have fixed and ankylosed facet joints will need to be osteotomized and then the anterior approach undertaken. Occasionally, even a 320 or 540 or a 720 or 540 approach is needed. In my practice, this is most commonly someone that's had a posterior surgery. They've got ankylosed facets. I go in from the back, osteotomize those facets, place my posterior anchors, then go to the front, do my anterior procedure, flip them over, put the rods in, correct the alignment at that time. When the disc space anteriorly is fused, an anterior or single column osteotomy is a relatively easy procedure as long as you protect the vertebral arteries. Typically, I'll try to identify the disc remnant. If it's not identifiable, I'll go halfway between the pedicles. The critical issue here is to take a verbiste approach between the longus coli and capitis, identify the vertebrals. The Penfield 4 placed between the vertebral body and the vertebral artery gives you a nice protection to then burr through the disc remnant and osteotomize the anterior column. And here you can see another case where osteotomy has been performed with significant correction achieved. Ideally, you want to perform multi-level ACDFs. If a corpectomy is required due to bone loss or retrovertebral stenosis, that's okay, but a hybrid approach, 2 single-level corpectomies is still better than a 3-level corpectomy in terms of restoration of alignment and fixation. When you're selecting levels for these procedures, you want to include all your stenotic levels. You certainly don't want to end the kyphotic segment. We talked about the anchors posteriorly, but I can't emphasize that enough. A C3 lateral mass screw is great as far as it goes, but in a patient where you have not been able to restore good lordosis and you've achieved that straight spine, typically that's going to be a weak anchor, and a C2 pedicle screw will be much stronger. The same thing's true with stopping at C7 in these patients. Often if C7 has a strong pedicle, that's good end-level fixation, but often in these patients I'll find myself going down to T1 to T3 depending on the severity of their deformity and how much thoracic kyphosis they have. In terms of planning these patients, it's important to simulate their positioning in the office to make sure that you can get adequate anterior support, anterior approach. At the time of surgery, making sure that you can adjust the head position as release and correction are achieved is helpful. A number of ways have been described for this, including blood pressure cuffs. Typically, I use a Mayfield type head holder and a C-flex, which is a device that allows you to adjust the patient intraoperatively without breaking scrub, but there are a number of different ways of doing that. I think the critical thing is I see people that make mistakes on these patients is they either didn't position the patient well, so their screw placement is off based on malalignment at the time of positioning, or they tried to achieve a reduction against the patient's body weight, which is nearly impossible. You need to have the patient's head weight or body weight work for you in terms of traction, in terms of a lordosing force. We talked about doing multi-level ACDFs when you can. A wide approach is very helpful in order to release the anterior osteophytes. Typically, placing converging Steinmann pins will allow you, as you distract them, to exert another lordosing force. Dr. Wang mentioned, but I'm going to emphasize today too, especially in patients with poor bone quality, there's no reason you can't place two Steinmann pins. There's no reason you can't place two Caspar pins. And as you place these pins, working at the disc level and at the pins sequentially going back and forth will help prevent pull-out or loosening of those Caspar pins. The posterior osteotomy is actually very straightforward for those people that haven't done it. It's basically taking your foraminotomy all the way out laterally. This is occasionally called a Smith-Peterson osteotomy of the cervical spine. For this to work by itself, you need a good disc space anteriorly, but in most of these cases, you're doing some kind of an anterior approach, as you see here, where the multi-level anterior fixation as well. Taking those big posterior osteophytes down gives you good bone graft, but also is critically important in terms of identifying proper anchorage sites and allowing the spine to start becoming a little bit more mobile. I don't know why those things flipped around. I think we're getting some issues with the slides here, but I'm going to move past. Not sure why that's doing that. There's an error with the slides. Here's an example of a posterior decompression. As we look at the outcomes for these procedures, historically all anterior surgeries in this context had poor outcomes. Typically multi-level corpectomies were performed, often with strut-type grafts. And that had a number of problems, including graft extrusion and failure to maintain alignment. As time's gone on, newer studies have shown significantly better correction and maintenance of that correction with modern segmental fixation and typically a multi-level ACDF type approach. Anterior-posterior outcomes are increasingly reported now as well, but typically small series of patients. These tend to be very powerful in terms of fusion rate, in terms of maintenance of correction, with typical corrections around 22 degrees achieved. But significant complications, of course, do occur. A number of other studies follow similar thought processes with significantly lower hardware complications and pseudarthrosis rates than either an anterior alone or a posterior alone approach at the expense of significantly more OR time and blood loss. Radiographic correction and outcomes in terms of NDI and VAS tend to be quite good with these procedures. It's interesting here, though, to compare this front-back front or back-front-back or anterior-posterior surgery with a three-column osteotomy. In some ways, it would sound simpler just to do your three-column osteotomy. There's not as much flipping of the patient and so on. But as you look at the data available, despite the number of flips of the patient, the complication rates, the blood loss, and the risk to the patient are still far lower with single-column osteotomies than they are with three-column osteotomies. And here you can see the differences in Kim's series in terms of blood loss. The ATO-SPO is the anterior single column and posterior single column osteotomy. And comparing the time in the operating room with the blood loss, it actually compares quite favorably to the PSO. In terms of degrees of correction achievable, a PSO is a bit better than the anterior-posterior osteotomy. But as you look at actual translation of the head back over the shoulders, the ATO-SPO at beats a 1-level PSO in terms of realignment. So I would conclude that there's a wide range of iatrogenic and degenerative cervical spine deformities. How you approach these should depend on the severity of the deformity and the presence or absence of neurologic compromise. And there's a wide range of options, though in the majority of these patients, prevention is certainly the best treatment, but if you're past that point, there's a fairly limited role for non-operative management in major deformity and myelopathy. For the vast majority of these patients, an anterior-posterior approach is recommended. In patients that have a very rigid deformity or a chin-on-chest type issue, that's where a 3-column or pedicle subtraction osteotomy would be recommended. Thank you.
Thank you very much.